Well, welcome everyone. Good afternoon and good morning, depending on your location. We're thrilled to have you all participating with us in the 25x5 Symposium to Reduce Documentation Burden on US Clinicians by 75% by 2025. I'd like to acknowledge the organizations that are participating in really making this symposium happen. So AMIA has been a wonderful collaborator and co-sponsor of this organization. The National Library of Medicine providing funding for this symposium, and Vanderbilt University and Columbia University. Great. And so I am Sarah Collins Rossetti, and I'm co-chair of this along with Trent Rosenbloom. And we're thrilled to have you here. As I said, would really thank the National Library of Medicine for their funding. And I'd like to acknowledge all of our steering committees who have worked over the past year on making this happen, both dealing with changes to format and certainly location. And it's been a wonderful group to work with. And we're really, really proud and thrilled to put this on for a really important problem. We know that nobody benefits from less resilient healthcare workers, and we know that clinician burnout is commonly reported and is in part due to electronic health record documentation. We also know that computer-based health records and information systems are intended to support healthcare workers and in delivering patient care, and in doing so, they should support both quality and morale. Unfortunately, this does not always occur. And so our motivation is really to work to strike a much better balance in this. The goals of our symposium are to establish strategies and approaches to reduce clinician documentation burden on US clinicians to 25% by 2025. In order to do this, we are and have engaged a diverse group of key stakeholders and leaders, and we thank you all for your participation. Also, to identify the potential for burden reduction within each documentation category, including identifying low-hanging fruit for quick wins, and to establish immediate, meaning less than 3 months, and short-term, within 6 months, approaches to reduce documentation burden, as well as generate approaches that can eliminate documentation burden in the long term, so within 10 years. Our principles of engagement for this symposium, we want to leverage technology and existing data inputs where appropriate. For example, in reducing documentation of items already captured during other intake processes. We want to make sure that the approaches we identify do not contribute to erosion of care standards, for example, for quality, safety, value, efficiency, and access to care. And we want to maximize clarity of proposed rules to minimize misinterpretation by health systems and providers. And importantly, we want to make sure there's no wholesale shifting of work from one clinician to another. In fact, when we look at documentation burden, what we really want to do is seek to eliminate unnecessary documentation altogether. You should have all received our pre-reading packet and resources via email, and I'll point you also to our website here, which has those resources as well as additional readings if you're interested. The website also has our agenda as well as additional information. So I'd like to acknowledge our session leaders, many of which are our steering committee members, but not all. Others are esteemed colleagues. And would like to acknowledge our wonderful speakers and panelists. It's a long list of really incredible experts in the field, and we look forward to hearing from them, their expertise and their opinions, and really to stimulate conversation around how we can solve this problem together. We're thrilled to have over 140 organizations participating in this symposium, and that's individuals representing a wide variety of roles. So frontline clinicians, that includes physicians and nurses, as well as other types of health professionals. We have academics, we have informaticians, we have We have folks from industry, we have individuals representing government organizations, we have individuals from different professional societies, as well as patient representatives. And here's just a snapshot of our agenda. This is also available on our website. So today we'll be doing our introduction and focus on current challenges related to what we document. We have two exciting keynote panels. Next week, we will focus on current challenges related to how we document with another two keynote panels. Our third session is focused on exemplars and key successes to see what we can learn from what we already know. And our fourth session is focused on emerging and future innovations as solutions. And for that, we're thrilled to have a moderated panel from experts in the field, as well as an industry panel discussion. Our fifth session is really for reacting and prioritizing what we've learned and where we go from here. We'll have breakout sessions to identify actions based on prior sessions and prioritize them as short-term, medium-term, and long-term. And in session 6, we'll have a plenary panel as well as continue that breakout work. So some requests from attendees: please put your full name in Zoom, and please do use the chat functionality for discussions and questions. We have chat moderators, and that's how we'll identify questions and bring them for discussion after each panel. Please also mute yourself if you're not speaking, and please use the gallery view. As I mentioned, we have some panels, and so that way you'll be able to view all of the panelists at once. We look forward to your engagement, thought leadership, and willingness to take action and participation in all 6 sessions and beyond. So thank you so much for joining, and I'm now going to pass it off to Judy.
Kevin, I believe you're taking it from here, right?
To Kevin, my apologies.
It's okay.
While Kevin's getting set up, this is Trent. Thank you, Sarah, for kicking things off. We're excited to have y'all here. I see 194 participants. Just to note that I put in the chat as well, please tweet. Use the hashtag 25x5 for your tweets, and that way we can aggregate them and people can follow them. Thank you.
Okay, just checking. Thank you, Trent. Can everybody hear me?
Yes.
Okay,
Yes.
Wonderful. So I don't have too many slides here. I want to make sure that I have a chance to do a little bit of stage setting. And once again, I want to welcome everybody who is attending. It looks like we have great attendance, and I hope you can stick with this for the entire thing. I want to make another point of just thanking Sarah. You have no idea how much effort this has taken. And a lot of people, Trent and others, were so involved. Sarah has done a huge amount of heavy lifting here, and I want to just thank her for that. So Judy Murphy and I had the pleasure of starting us off with, I think, 2 outstanding sets of panels. And the format you're going to see all day today is going to be essentially 10 minutes per speaker and then Q&A. And we'll get into that in a little bit more detail, but that's essentially how we started. And I'm going to try to zip through this one so that we can hear more from you and them than you do of me. But I want to start by talking about this overall session today, which is current challenges related to what we document. Notice what in italics. One of the realities that many of us who are in ACME, which is the American College of Medical Informatics, and who think about this field are wrestling with, and I think about many of the people who are panelists, is that in fact, we are a part of the problem. And I say that kind of lovingly because I was a member of the group of people who started in a report that we put together for the Agency for Healthcare Research and Quality, then under Carolyn Clancy, called Key Capabilities of an Electronic Health Record System, a report that was really designed to help AHRQ with their plans for going forward, both studying but also working on policy to improve access to the EHR. And I want to direct your attention to the box that's on the right. That box was one of the many reports that came out around the same time as the computer-based patient record report that said there are many primary and secondary uses of an electronic health record system, some of which were in common use in those sites that already had EHRs, many of these were envisioned. And this was adapted from this report that was done by the Institute of Medicine called the Computer-Based Patient Record, an Essential Technology for Healthcare. And I point out to you many of these secondary uses, all of which have now come true: education, regulation, research, public health, homeland security, and policy support, as well as the ones on the left. At the time, our thinking was that it was extremely important for physicians and nurses to be a big part of the direct data capture so that we could enable, using informatics, automated and computational strategies to address all of the primary and secondary uses that you see on this slide. The other reality that I think many of us have seen comes from these data that were generated by Epic and reported out by David Bates, Chris Longhurst, and Lance Downing. And a big part of what this report described was that when one looks at the US record note length compared to international health record note length, there's a very clear distinction. And as you can see here, the US notes are the long ones and the international ones are the short ones. And without really even thinking about this more, it's pretty clear that what we document is a part of our history in informatics, and therefore are part of what I think should be our future. And you're going to hear our panelists talk a bit about this today. There are many reasons for this. There are policy reasons. And so therefore, Judy and I decided to divide us into these sections. There are sort of policy reasons, which are regulation, reimbursement, quality measures, and others. And there are practice reasons, new data sources, some of which we haven't thought about, but we know exist and are coming, litigation concerns, and then brand new data needs, things like genomic medicine, things like equity. You'll hear some of this today. And so we are really pleased to have two panels that can talk about those specifically. We start off with Andy Gettinger, who is going to talk about the ONC Cures Act final rule and challenges tackled. Mary Green, who is well known to me personally. I worked very closely with Mary at Hopkins. She's now really the lead on documentation and burden, physician burden for CMS, and is going to talk about documentation requirements, balancing quality, safety, and program integrity. And Brent James, who's well known to many of us in the quality space. Currently, I have other people's titles here, and I'm trying to keep us moving. So I'll let everybody say a little bit about who they are as we come up. But Brent James, who's known to many of us, who's going to talk about quality measurement for ranking versus change, implications on expense and burnout. Judy, would you like to say a little bit about our second group of panelists?
Absolutely. So we've got three additional experts in panel 2, really talking about clinical practice and the documentation issues. And first up will be Sharon Kirby from CNIO from Mayo Clinic. She's going to talk about nursing documentation as well as medication reconciliation and some of the trials and tribulations around that. We have Sherry Hess, who's the Chief Nursing Informatics Officer at Banner Health. And she's not only going to talk about, the documentation burden, but also the cognitive burden that puts on us, meaning once we have all this additional information coming at us, how do we sort through that so we know what's important and what's not important when there's a plethora of information? And then last but not least, Ken Riccato from Columbia University is going to talk about diversity, equity, and inclusion and some documentation considerations in that space.
So thank you. So to summarize how this is going to go today, session 1 will have 3 10-minute talks about policy and reimbursement. There'll be 3 presentations, 10 minutes each. Then we'll have Q&A. Then we will have a second panel on clinical practice and documentation, 3 presentations, 10 minutes each, followed by Q&A. And then we have planned a session at the end to summarize and prioritize, or a section of the session, to summarize and prioritize the challenges related to the what we document with you all, the audience, and using polling. And we're excited to see how this comes out. All of these data will feed into what we finally think about in sessions 5 and 6. So it's very important that you hang on with us. Please do, and be a part of this entire process.